Clinical Hematology Series Part 2 by Clinical SWOT. Megaloblastic anemia. This results from a deficiency of vitamin B12 or folic acid or from disturbances in folic acid metabolism. Cells become arrested in the development and die within the marrow. This ineffective erythropoiesis results in expanded hypercellular marrow. Hemolysis within the marrow results in raised bilirubin and lactate dehydrogenase levels but without reticulocytosis. Now, the causes of vitamin B12 deficiency. The first is dietary deficiency. This occurs in strict vegans. It can occur in any age, but the main onset is between 10 to 80 years. The second is gastric pathology. The release of vitamin B12 from the food requires normal gastric acid enzyme secretion, and this is impaired by hypochlorhydria in elderly patient or patient following the gastric surgery. If the patient undergoes total gastrectomy, 3 monthly vitamin B12 injections are needed, and if patient undergoes partial gastrectomy, annual injection of vitamin B12 are required. Now the third cause, and one of the more important, pernicious anemia, organ-specific autoimmune disorder in which the gastric mucosa is atrophic with the loss of parietal cells causing intrinsic factor deficiency. Average age of onset is 60 years, and in this, antiparietal cell antibodies are present in over 90% of cases. For the diagnosis, Schilling test is done, which involves the measurement of absorption of radiolabeled B12 after the oral administration and before or after the replacement of intrinsic factor. The other causes include small bowel pathology, motility disorders, hypoglobulinemia, fish tapeworm, diphyllobothrium lactum, or any inflammatory disease like Crohn's disease or ulcerative colitis. Symptoms like anemia, stomatitis and glossitis, neuropathies like loss of position or vibratory sensation in lower extremities, ataxia, increased deep tendon reflexes, spasticity weaknesses, Babinski sign, loss of urinary and fecal incontinence, impotence, and dementia. Diagnosis of vitamin B12 deficiency. The first of all, peripheral blood smear is obtained, in which we can see megaloblastic anemia, that is MCV greater than 100, and also hypersegmented neutrophils can be seen. The second is serum vitamin B12 levels are low, that is less than 100 picogram per ml. The third is serum methylmalonic acid and homocysteine levels. These are elevated in B12 deficiency. The fourth is antibodies against intrinsic factor, which can help in diagnosis of pernicious anemia. And the fifth is Schilling test, which is also used for diagnosis of pernicious anemia. Treatment of B12 deficiency. It is treated with hydroxycobalamin 1000 microgram intramuscularly for 6 doses 2 to 3 days apart, which is followed by maintenance therapy of 1000 microgram every 3 months for life. The second part is folate deficiency. Mainly folate is produced by plants and bacteria, hence present in dietary leafy vegetables, and animal protein or animal organs like liver or kidney are the rich sources for this. The main causes of folate deficiency are poor intake of vegetables or celiac disease, or when there is increased demand of folic acid like in cell proliferation, pregnancy or hemolysis, and drugs that cause folate deficiency that are anticonvulsants like phenytoin, contraceptive pills, or any cytotoxic drugs like methotrexate. In the diagnostic findings of folate deficiency, we can see serum folate levels are low, low red cell folate levels which indicate prolonged folate deficiency, and macrocytic dysplastic blood picture or megaloblastic marrow cells. For treatment of folate deficiency, we can give oral folic acid 5 mg daily for 3 weeks. This will treat acute deficiency, and 5 mg once weekly is adequate for maintenance therapy. Prophylactic folic acid in pregnancy prevents megaloblastosis in women at risk and reduces the risk of fetal neural tube defects.